As dentists, obtaining profound dental anesthesia is an extremely critical part of our jobs. Patients trust and value a dentist who can get them numb and complete their procedure without experiencing any pain. Over the years, I've come to rely on the CT scan as my co-pilot in this task. By reviewing the tooth's anatomy prior to administering anesthesia, I can learn a lot about where to administer the anesthesia for its most profound effect. The good news is if you don't have a CT scan, the majority of patients have similar anatomy. So if you follow this protocol, you should be good. Let's look at a CT scan to demonstrate this in both the maxilla and mandible. Later on in this video, I will show you on an actual patient these injection sites and how to give these injections with minimal discomfort. The axial slice in the upper left is best for reviewing anatomy prior to administering anesthesia. In the maxilla, all anterior teeth require only buccal anesthesia. This is because of their close proximity of the apex to the buccal plate. Premolars may need buccal and lingual anesthesia depending upon their anatomy. If you look at the maxillary first premolar, you can see that the roots diverge as they extend apically. A quick measurement tells me the lingual root is approximately 8 millimeters from the buccal plate. Palatal anesthetic would be necessary when treating this tooth endodontically. Maxillary molars require both buccal and palatal anesthetic as a result of the divergence of the roots. Mandibular anterior teeth typically only require buccal infiltration. Occasionally, lingual infiltration will be necessary if the apex lies closer to the lingual plate. I don't give a mandibular block for endodontic therapy on lower anterior teeth. For mandibular premolars, I'll give 1 carpule of lidocaine 1 to 100,000 with epinephrine as a mandibular block and then infiltrate with 1 carpule of septicaine. If you don't have a CT scan to review the anatomy, I suggest you inject half the carpule on the buccal and half the carpule on the lingual, positioning the tip of the needle as close to the apex as possible. You can see this tooth actually has 1 root that diverges into 2 apically. For mandibular molars, similar to premolars, I'll give 1 carpule of lidocaine 1 to 100,000 with epi as a mandibular block and then infiltrate with 1 carpule of septicaine. However, the location of the root apex of the first and second molars is completely different. The apex of the first molar is typically located between the buccal and lingual plate. While the apex of the second molar is located much closer to the lingual plate. Therefore, buccal anesthesia is of no benefit pulpally for lower second molars. As a result, all first molars will receive half a carpule of septicaine on the buccal and half on the lingual, and the lower second molars will receive 3/4 of a cartridge of septicaine on the lingual. This is a mandibular lingual infiltration for tooth number 19, which is done by slowly injecting a half a carpule of septicaine at the level of the apex on the buccal and half a carpule of septicaine on the lingual. For the maxillary palatal injection, I'll apply refrigerant spray, such as endo ice, to the palatal tissue prior to injecting. You can also use the end of a dental mirror handle if you prefer. If using a refrigerant spray, saturate the end of a Q-tip with the endo ice. I immediately place the Q-tip on the palatal tissue for 5 seconds. Then, while leaving the Q-tip in place, insert the needle and begin injecting very slowly. I inject a half a carpule of lidocaine 1 to 100,000 with epinephrine over the course of 1 minute.